let me start by welcoming everybody. Thank you for digging yourselves out of the snow to join us for this pulmonary critical care and sleep medicine ground rounds. It is my distinct pleasure to introduce to you Dr. Monique Hinchcliff. So Monique is an associate professor of medicine in our Department of Medicine in the Division of Rheumatology, where she wears many hats. She's the director of the Yale Scleroderma program, also the director of clinical and translational research, and also has the clinical translational research accelerator. So Monique trained in Rosalind Franklin for medical school, was a resident and was a fellow at Northwestern, and then she got recruited to Yale to be the head of the scleroderma program, who's now been recognized as a scleroderma center of excellence. She has won many awards, which I want to highlight that she has won teaching awards both at Northwestern and here. She has a stellar track record of NIH funding. She's on the editorial board of multiple rheumatology journals and also has been part of multiple important clinical trials. She's been in the guidelines for screening connective tissue disease, ILD. She's been in the scleroderma lung study. From a personal note, it is a pleasure to have her as a clinical colleague and as a research mentor. She has been outstanding. We're very lucky to have her here at Yale. So we'll hear her talk about intravenous epoprostenol for threatened digital loss in the MICU.
Thank you so much.
Yeah.
So I would say I have a stellar track record of not getting grants funded by the NIH, right? It's like for every 10 you submit, you get one funded. So I'm like everybody else, I suppose. It's a pleasure to work with such talented mentees. So I've been blessed with several. So I was asked to a while ago, when I first arrived at Yale in 2018, I think the first person I met with, or first person who reached out to me, was Indy Singh. And he said, we're getting these patients in the MICU that show up with gangrenous fingers, and we really, we're lung doctors. There's no fingers in the lung. I don't know why you guys send them. And the rheumatologists were sending the patients for IV epoprostenol, but there was really no pathway set up or any kind of protocol to treat these patients. And so it caused a lot of consternation, I think, in the MICU. So the first thing really the first project that I took on along with Dr. Singh and Diana Lemieux, who I understand has left, right? She departed, unfortunately. And I include her here on the slide deck because she helped put a lot of these slides together. The first thing we did together was to develop a protocol for administering IV epoprostenol for these threatened digital fingers and toes in the MICU. So thank you for the kind opportunity to present to your group, because I think it'll hopefully prevent a lot of confusion on your end when we refer mostly our patients. So you can see, not so typical, but you can see a patient with severe Raynaud where the fingers are clearly white. We don't often see it this dramatic. It's usually harder to detect. And then here, we have images. This is a normal nail fold capillaroscopy. So the nail would be here. And you can see these little tiny capillaries that are just below your cuticle. And in all of us, presumably, they're normal. They're normally spaced. They're normally sized. They look uniform. So this is normal. And this was taken by a former fellow of ours, Abhishek Manathanapalli. And he published a paper where he looked at using Dynolite in clinics. So these images were taken with a handheld Dynolite. It was like $700 instrument. You can hook it up to your laptop and you can take these images. And it was really to show that this is feasible to do in a rheumatology clinic, because this was not done in a research setting. And I hope you can appreciate that there's distinct differences between a healthy individual and a patient with scleroderma. You'd see similar findings in a patient with dermatomyositis or systemic lupus. And this is a high power view. And this is the most specific finding for systemic sclerosis. This it's been described to me as pebbles, thrown into the water. And these denote microvascular bleeds at different points in time. And so that's why there's like this skip pattern. If I used Dynalite on any of your capillaries, I would probably find a couple of these just because you picked your cuticle or you banged your hand. So a couple is not abnormal. It's really when you're seeing them on most of the fingers that it's suggestive of secondary Raynaud, and we'll go through that. So the learning objectives, understand what is known regarding Raynaud phenomena pathogenesis, which there's still much that we need to learn. Learn to manage patients with threatened digital loss in the MICU. That's really the part for you all. And then for us, more rheumatologists recognize the mimics, but certainly that would apply to your group as well. When we get it wrong, when we think it's Raynaud and we treat the patient with IV Epoprostenol and the patient's not improving, and that unfortunately I hear happens not infrequently. So we need to screen our patients very carefully. So one of the cardinal features of systemic sclerosis is vascular pruning. And again, you can see these nail fold capillary images. This is normal, early, active, and late. And this is a classification that was published. Again, it's very hard to do this unless you have video nail fold capillaroscopy. I have a derm light in clinic that I pull out of my pocket and I just take a quick peek for diagnostic purposes. You don't get images like this with just looking with a derm light. This is a patient that we're currently treating. He's a patient in our program. And this is just to show how the vasculature can be so severely damaged in patients with scleroderma. So a kidney from a healthy person who succumbed to something. So this is their vascular tree. And this is a patient who died of scleroderma renal crisis, which manifests as hypertension, progressive hypertension. And usually that's the only sign. Most times it's asymptomatic. So we do a lot of counseling in our clinic to encourage patients to be checking their blood pressures. So what is Raynaud phenomena? It's reversible. It's symmetric vasospasm of the arteries and arterioles. So it does occur in arteries. It's not just capillaries. And it occurs in acral body segments. So we see it in the hands and the toes, but it's occurring in the heart. It's occurring in the esophagus, probably in the kidney as well. It's an exaggerated physiological response to cold or emotional stress. So I'm a little nervous and my hands are a little cool. They might be changing color, and blood is being shunted away from my surface of my fingers to maintain my core body temperature. And you all know that probably very well, because you can't be cold and dead. You have to be, right? So you know about the thermoregulatory systems of our bodies. So it most often involves the fingers. So patients will say, my screening question is, what happens to your fingers when you're exposed to colds? Don't ask them if their fingers turn colors when they go out in the cold, because of course everybody's fingers turn colors. So that's not a good question. Ask them what happens. And if they give you this description of they turn white and it's really painful, and then they turn, that's a better screening, a better way of getting at a true Raynaud phenomena history. It can involve many acral body areas, and the changes are typically white, so that's ischemia, that's painful. Patients will report pain with that. Blue, and then followed by red, which is the hyperemic response to the vasoconstriction, and that often too is also painful. Blue is, albeit looks bad, and patients mind it because they'll get asked what's wrong with their hands. It's typically not painful. So again, there's primary and secondary Raynaud. You all know this. I wasn't sure if there'd be medical students in the room, but primary, we don't really need to go into that. Occurs earlier, not associated with the disease. Their nutritive skin blood flow is preserved. It's just the thermoregulatory blood flow that gets shunted. But in secondary Raynaud, so in our diseases, and I'll show a slide later from Up to Date that shows all the diseases that are associated with Raynaud. It's typically, the onset is later. It includes the thumb. Another secondary disease is present. They do have those nail fold capillary abnormalities that I showed you, and they have severely diminished nutritive flows, and that's why they get the digital ulcers. So usually people, when they're exposed to cold or emotional stress, they'll maintain the nutritive blood flow to the skin, to the top of the skin. And in patients with secondary Raynaud, they lose the nutritive flow completely. And so that's why the ulcers are formed. So here's another image. This was published in the New England Journal of Medicine. You can see the blue color, which again is typically more concerning to the patients, the normal nail fold capillaries. This condition was described in the 1862 as Maurice Raynaud's PhD thesis, but it's really common in the general population. It seems to have a genetic predisposition, as you can see from the first-degree relative association as well as the twin studies that have been conducted. So here's the list as promised, as all of the things that are associated with secondary Raynaud. And so this is a big laundry list, and we've had some cases recently where we have thought the patient had cryoglobulinemia, but we weren't able to prove it. Berger's disease, I got called a few weeks ago from someone in the MICU. There was concern for Berger's disease. So it's important that we're all thinking about all of these different things that can be causing secondary Raynaud phenomena. So the pathophys is pretty simple. It's just an imbalance of vasoconstrictors and vasodilators. So too few vasodilators like prostacyclin and nitric oxide, and too much thromboxane A2 and endothelin 1. And so just this imbalance is what's thought to cause it. So the treatment is related to that underlying pathophys. So here's the treatments. We have calcium channel blockers. The dihydropyridines are the first line. So we use nifedipine first line. That often causes lower extremity edema and worsens patients' GERD because of the smooth muscle dilation. They note more gastroesophageal symptoms. So it's not uncommon for patients to not be able to tolerate nifedipine. And in that case, we typically switch to amlodipine. We'll add on losartan. There's one study by Desadio that looked at using losartan and showed a favorable result. The phosphodiesterase 5 inhibitors, which I'm sure you're all very used to administering. I prefer tadalafil because it has the longer half-life and I only have to dose it once per day. Patients don't forget to take a dose. Endothelin receptor antagonists have been studied and have only been shown to prevent new ulcer formation. They've never been shown to help the healing of an existing ulcer, and they're often not covered by insurance. I can count the number of times on one hand that I've been able to get them covered. So I usually don't even try anymore to get those covered. I use all these other therapies, discussing with patients. There's also, you can give Botox injections to the base of the finger. None of the things in the other category have a lot of data to support their use. They're just things that we can try as adjunctive therapies with plus minus good effect. But the last line that my last bottle that I pull off the shelf is Epoprostenol. And I try to manage these patients on my own, but occasionally I need your help. So prostacyclin, I think this group knows this pathway well. It's a byproduct of arachidonic acid. It binds to its receptor and, long story short, results in smooth muscle cell vasodilation and anti-proliferation of smooth muscle cells, but it also has antiplatelet effects, mild antiplatelet effects. So for those reasons, it's thought to be helpful in patients with Raynaud phenomena. This was an interesting paper that I saw as I was preparing for this talk. It's well known that the endothelium, the arachidonic acid, can be derived from the endothelium, but its newer paradigm suggests that, at least in the lung, fibroblasts may be the major cell type secreting prostacyclin. So I thought that was interesting for this group, especially. They're also reported as a sex dimorphism in endothelial cell dysfunction. This is not a definitive paper on the topic, but I thought it was interesting because they had male and female mice. They tampered with the mice so that they could trace the endothelial cell lineage, so they could see them under the microscope with this fluorescent tag. And they saw that when they fed the mice a very high fat diet, the female mice showed a higher lipid burden, loss of endothelial cells in the lumen right here, more oxidative stress and more apoptosis, as opposed to the male mice, which you can see they had more endothelial cells lining the fibrous cap, had less of a pathological response. So, and we definitely see that in our patients, that far more women suffer from Raynaud than males do. So the first classification that where epoprostenol or Flolan was included was the 2016 EULAR, European League Against Rheumatism guidelines, where they said this meta-analysis of randomized control trials on prostanoids indicated that this intravenous iloprost was beneficial, and they recommended that we should use it in patients with severe attacks, and then also use iloprost in the treatment of digital ulcers. So that was the first time it was in the guidelines, and then it was recent guidelines came out in 2023. Again, it was included that we should consider iloprost for digital ulcers and systemic sclerosis Raynaud phenomena with good evidence. We don't have iloprost in the United States, so that's where we use epoprostenol, which is why I crossed out iloprost on this slide. So the half-life is 6 minutes, and hopefully that'll help answer some of the questions that makes folks in the MICU get nervous. If anything goes wrong with these patients, you just turn off the flow, and it's gone within in a half an hour. It can only be administered intravenously, as you know, and it has, whereas Flolan used to have to be refrigerated, epoprostenol does not, and the typical infusion is 5 days for these digital ulcers. There was concern at where I came from at Northwestern that giving epoprostenol through a peripheral line would result in thrombophlebitis. So when I came here and spoke with Indy, I said, we need to put in central lines, and he said, no, we don't. So, and lo and behold, we've been doing it and through peripheral lines for all these years, and we haven't had any issues. So I think it was more of a theoretical concern than an actual concern. We haven't had any problems with that. So this group will know all of the physiological effects of IV epoprostenol. So I don't need to go through this, but interestingly, it doesn't reduce the mean systemic arterial pressure very much. So I'm not sure why that is, but maybe one of you has insights into that. So this was our timeline of IV epoprostenol approval at Yale New Haven Health. So it got approved in 1995. We as rheumatologists were getting more and more interested in using it for our patients with refractory Raynaud phenomena with digital ulcers, and we're referring patients to you all for this treatment. In 2018, it became really problematic, I think, is from what I was told. And so Indy, Diana, and I worked together with pharmacy and the hospital leadership to develop an inpatient epic order. So there's an order set, and many of you've probably used it. How is it? Works pretty good? Yeah. It's good. It's good. You're happy with it. Okay. So it's in there, and, pharmacy was involved. We involved nursing to make sure that everybody was on board. So it worked really well. And then something happened between 2018 and 2023 that made admitting a patient to the MICU more difficult to save fingers. And of course, we all know that was COVID-19. And so it became very clear that we needed an outpatient IV epoprostenol program. And Vi was critical. My clinical chief, Vi, Dr. Chowdhury, played a critical role in bringing this to fruition, as did many of the leadership. But we started the first program at St. Raphael Hospital because there was a local emergency room, and there was concern, especially among nurses, that patients would decompensate. So we started it at St. Raphael, and then the next place was Fairfield Infusion Suite. just because there was so much need. And then we opened up at Greenwich Hospital, and our most recent launch has been in the North Haven infusion suite, which is so full of other patients that it's seldom used for IV EPO, but that's in the outpatient setting. But I just want you to know that when we refer to the MICU, it's usually not because for a lack of effort in managing these patients in the outpatient setting. So in your world, the inpatient workflow, you don't have to worry about Medicare or Medicaid covering the infusions. They do. In private insurance companies, we have to call to get prior authorization before we send the patient. It's not recommended to send patients to the ED because they can sit there for days. So I usually tell patients to stay put. I call Yale Access, see if there's a bed, talk to the MICU attending. When a bed becomes available, I give another report to the actual MICU attending, because the one that I first spoke to is never the one that is there, when the bed opens up. So I give report to that doctor, and you all have been so gracious in accepting the patient, so thank you. And then I usually just, it's just follow the order set. All the information is in there, but a couple questions do arise. So that was the reason really for this presentation. More from our side, but also I think it's important. I mean, you are the ones who are ordering this medication. Is it Raynaud phenomena, which will respond potentially to IV epoprostenol? So, you should double check us too. History of vibration injury, peripheral vascular disease, arterial disease. Is it an acute thrombosis? Is it fibromuscular dysplasia or embolism? One of our weird rheumatic or blood diseases, we have seen those, or other, we should all be checking each other. So the pre-infusion evaluation, this is something that I neglected on one of the patients who was taking a migraine medicine. And so she was taking, a triptan, which causes vasoconstriction. And then we were giving her IV epoprostenol. So one of my colleagues suggested astutely that we stop the triptan. Patient got a terrible headache. So that's one concern. But any kind of stimulant, migraine meds, ADHD meds, we should, at least discuss with the patient about holding them. Of course, Jolt and Red Bull, all of these, they shouldn't be drinking Red Bull while they're in the MICU getting their IV epoprostenol. We didn't put in the pathways that the patient had to have an echo within the last 6 months or had to have a right heart catheterization, because we thought that just wasn't feasible and not necessary. Other sites require an echo within the prior year, but if the patient is having no symptoms and they're exercising, we thought that was overkill. And so we just asked the patient about if we think there may be concern for pulmonary hypertension, we do that workup before we send them for the IV EPO. Heart failure, of course, is a concern. Not really, though, at least not in the outpatient setting, because Indy's like, you're giving them such a small dose, like, don't worry about it. But in your purview, it would be a concern. And then, of course, recent bleeding, GI bleeding, we should be on the lookout for, in chronic kidney disease because of the antiplatelet effects that I mentioned. So this is the protocol. In the MICU, you start at 2 nanograms per kilogram per minute, and you titrate up to a max dose of 10 nanograms per kilogram per minute. In the outpatient setting, we start at 0.5 and we only go up to 2 nanograms per kilogram per minute. So 6 of our patients have received this both in the outpatient and the inpatient setting. And it's usually for the fact that we can just give such a higher dose in the MICU. Here's the outpatient order set, but the inpatient order set looks similar. Here's our safety questions. You just want to make sure the patient's not in fluid heart failure. You've thought about pulmonary hypertension, and that you may need to request a PICC line if the nurses are unable to get IV access. So this is the side effects that are included in the package insert that come with epoprostenol medication, at least from 2021. And I highlighted the ones that we've seen, that I've had patients tell me about. And I'm sure, many of these other things they've experienced and haven't thought to mention to me, but we have never had to stop an infusion completely because of any kind of side effect. So this is what we do. First, we slow the infusion rate, headache. You can see the treatments, jaw pain, you can see that these are the things that are recommended. The site pain, I wouldn't say an ice pack, maybe just a cold pack, because again, we're trying to vasodilate them. During the MICU stay, I've come in there and my patients are freezing because it's maybe, the temperature is cold. So, just be cognizant if the patient's freezing and we're giving a vasodilator, we're kind of, negating the positive effects. So do you still use bear huggers? That's a thing from my training as a resident, the heated blanket with the air flowing. Do you still all use those? Yes. Okay.
There's a specific temperature cutoff that they use, like when you want to order.
Okay. All right. Well, it would help, a big warm blanket or just lots of blankets. The other thing are opioids. We have to control pain. Pain is such a potent vasoconstrictor. I explain it to patients. It's a physiological need to have pain be a potent vasoconstrictor. So I don't think it really makes much sense to be giving patients vasodilators and then allowing them to sit there with 10 out of 10 pain. It's extremely, extremely painful to have these ulcers on your fingertips. I have ordered pain consult and received recommendations to start Tylenol or start Ultram, which I know doesn't do anything for the severe pain of a digital ulcer. So this is an instance where I prescribed Norco in the outpatient setting. I haven't had any issues. I follow the guidelines for prescribing opioids, but I really do feel like this is one instance when we should be giving opioids to our patients. We have also had concurrent cellulitis and osteomyelitis present. That was a case that we had earlier this year. So we worked closely with ID. I thought my understanding was that you get an x-ray, and if the x-ray is inconclusive, then you go to an MRI, and the MRI will either confirm or refute that there's osteomyelitis. And I was told by my ID colleague, it's not so simple. To definitely start with the x-ray, but even if the MRI is abnormal, it may or may not be osteomyelitis. So I don't have a clear understanding as how we exactly determine whether the patient has osteomyelitis without a bone biopsy, which of course we wouldn't want to do in this setting. So I have a low threshold for starting antibiotics. And again, just reviewing the outside med list. So that the palm trees there represent keeping your MICU environment warm for our patients. Once the patient, even if they're not on a stable dose, as you can see, some of the titration can be done on the floors, but definitely once the patient is on a stable dose, they can be transferred out of the MICU to free up a bed. And this was information that we received from the inpatient pharmacist. So the patient does not have to stay in the MICU for the entire duration of care, which again is usually 5 days. And then the other question I get asked a lot from your colleagues is, do we have to titrate this off? Like, do we just turn it off? And the answer is, yeah, that's what we do. We just stop the infusion and maybe wait a half an hour, check vitals, make sure the patient's feeling okay, and then we send them home. We don't have to titrate it down. So our experience thus far, we've treated, I don't have information for the entire health system, but I do have information for the Yale scleroderma program. So we've referred 18 patients to you who've received this treatment in the MICU. 27 patients have been treated in the outpatient setting, and I list the dates of when those sites became open. You can see the common side effects. Again, none led to the cessation of therapy. Patients continued the therapy. The most common reason for stopping therapy was the time that it takes. It's a 6-hour outpatient infusion, and patients don't want to come into the MICU necessarily for several days. So it's more of a time commitment that prevents patients from continuing with the therapy, and perceived lack of efficacy. It doesn't change right away. I mean, for those of you who've used this in the MICU, you're just there's tissue that's already dead, and it's dead, and we're not going to bring that back. What we're trying to do is spare whatever remaining live tissue, which is underneath the dead tissue. So it is not expected that the patient's finger will look better. What we can follow, I think, is pain. So if the pain is decreasing, that's usually a sign to me that the therapy has worked. And it's not going to get rid of their pain, but the pain diminishes. And so I consider that an effective treatment. Why do we not give IV epoprostenol in the ED? I told you patients get stuck in the ED for several days waiting for a bed. And we looked into that. And apparently, I mean, that's a whole nother approval process. That's completely separate from the hospital. So if any of you residents or fellows would like to take this on as your quality improvement project, I'll give you all of the tools that you need to make this happen. It would be great for patients, but yeah, I haven't crossed that bridge. But it would be great if we could do that. So here's some IV epoprostenol successes. This was, I think, the first patient who I ever gave IV epoprostenol to. He was admitted in late June. Plastic surgery was consulted and deemed that IV epoprostenol was not necessary. And my fellow didn't fight for it. So the patient, and I was on vacation, the patient was sent home. You can see what the finger looked like just a few months later. It was still excruciatingly painful despite all many different treatments that we had been giving, the calcium channel blockers, phosphodiesterase 5 inhibitors, antidepressants. And so we readmitted this patient for IV EPO. He underwent 5 days of treatment, and this was his finger back in clinic by May of 2021. So I'm saying it doesn't heal quickly. This is a slow, arduous process. And he did continue on hydrocodone for many months while this was healing. This is another patient success story. This is just, this month. Look at this. This was his finger last summer, super painful, had seen surgery, who were happy to remove his finger, but he's right-handed. And there's a hierarchy of importance of fingers, right? So the thumb and the forefinger are your most important fingers. You use that to hold, for opposition, to turn a key, to turn a doorknob. You really need those two fingers. So I encouraged him to not go through with surgery and to just, give it some time. So we treated him maximally. This looked great. He and his wife were scared to death of this. Dry gangrene. I'm like, this looks great. And they looked at me like I was crazy. This looks so much better than it did back in April. And they were surprised at my response. This was in November. It starts to get cold again. The fingers were getting painful. So we admitted him for the IV epoprostenol. And this was just in clinic a couple weeks ago. He is going to make a $10 million donation to Yale. Just kidding. So we had successes, but we've had some misses as well. So I know this isn't an M&M case, but this is another patient of mine who I started seeing in 2023. She was referred by an outpatient rheumatologist, and the referral was for severe Raynaud phenomena. And perhaps I, went down, that lane of thought and didn't get, I remember, and I documented many other diagnoses that I considered, but I thought it was Raynaud and was treating her like a Raynaud patient. And we don't really know what she has, to be honest with you. We had a discussion of her case. Couple times her cryoglobulins came back positive, but then on retesting, they were negative. She responded to heparin, and she's been responding to not anticoagulants, antiplatelet therapies, oral antiplatelet therapies. So she did have a skin biopsy, and it showed microthrombi. And so we got hematology on board. And again, she's seen so many people. And again, we don't really know, we still don't know what she has. We've done a thorough cancer workup, thorough rheumatologic, hematologic workup. We're going down the genetic rare syndrome tree because we just don't know what she has. But she's getting better on heparin and antiplatelet medications. This was another case not known to me. Again, unknown what this patient had. But when I saw this picture, I told them that is not Raynaud. That I don't know what that is, but it isn't Raynaud. This could be Raynaud. But this hand, this is to be determined what that patient had. And I don't think IV EPO was effective. We didn't really find much improvement. So, I think you think about those cases that perhaps you missed or you could have done a better job for the patient. And I think, just going back to the basics, trying to assess that for the tricolor changes. It's so rare that patients say that they have the red, white, and blue changes or the white, blue, red changes. But, maybe I led the patient and didn't let her use her own words to give me that diagnosis of Raynaud, because again, she came with that diagnosis. And then the abnormal capillaroscopy, again, I use derm light, and I think I need to invest, in my personal, like I have a stethoscope. I think I need to buy a derm light and have that in clinic with me so I can see those 200-time images and not be relying on the 50-time magnification that you can see with a derm light. So that's what I learned. That's what I'm going to do. So in summary, IV EPO is a potent vasodilator and has weak platelet aggregation inhibition. Half-life is super short, so nurses don't need to, I just don't think we need to be as worried about decompensation because we just turn it off and the patient, it's out of their system quickly. It's approved for treatment in the MICU for 3 to 5 days. It's approved in the outpatient setting for any time for 1 to 3 days per month for as long as they need it. We have given it at Yale Health for a professor, musician professor. So we've been able to get it covered there, and it's been well tolerated and safe giving it through a peripheral line or a catheter for that one professor. So future work and things that I hoped that we could discuss in the time that we have remaining is, I think it might be useful to have a multidisciplinary group that's interested in these cases that would be comprised of a dermatologist, an ID specialist, rheumatology, one of you, and then, a pain specialist who would be willing to prescribe opioids. I've taken that on myself, and I wish a true expert would be managing pain. What is the role for surgeons in this regard? Because whenever a patient sees a surgeon, the surgeon always says, yeah, I can take that off for you. Yeah, which they, they're surgeons that of course, they can remove a finger, no problem. But, is that really needed? And is that really in the best service of our patients? Should we be discouraging patients? So I was taught by Fred Wigley, who's kind of the father of Raynaud, who's at Johns Hopkins, that there's three indications for amputation. One, intractable infection. You just cannot clear an osteomyelitis. 2, intractable pain. In spite of all the pain medicines, the patient remains in pain. Or 3, the patient just has had it, And so by the time the patients get to me, they're at that threshold that they've kind of had it and they're ready to go for surgery. And that's when we have a discussion about, I pull out my laptop and show them the picture of the first patient. Look at his finger. We saved a finger. And so we've been successful. So don't call surgery because they're always going to want to remove the finger. And then I guess another question for the leadership is, how do we expand throughout the system? So how do we make this happen at Lawrence Memorial and Westerly Hospital? Like if we're one Yale, if we're really one true medical center, this should be available everywhere and not just at outpatient clinics and here in our MICU. We should share the love with our other colleagues, right, in the other MICUs. So this is the Yale Scleroderma program, and just a special thanks to all of my pulmonary medicine colleagues. Blurta Green is our newest. I'm not like Danielle with this whole entourage of people who want to be like Danielle. I've had a really hard time getting anyone to join me, but Blurta has graciously, she's one of our fellows who graduated, and she's going to start seeing scleroderma patients in Hamden at Debbie Desir's former private practice. So that's really going to be great. I think it help with our accessibility. And I didn't mean to be insulting. Each of you is all wonderful in your own right. I'm not saying you're Danielle minions, but you know what I mean. Like you joined the program that Danielle is directing. So you just have a fantastic group of professionals and it's been a pleasure working with you. I hope to continue that. And special again, thanks to Dr. Singh, who was really, really instrumental in getting that protocol written up. So thank Indy the next time you see him. And that's the end. That's the end of the talk. So I hope that's helpful for you all.
Thank you, Monique, for a wonderful presentation. This is very practical because we get called. Remember the first time I got called for a EPO admission for Raynaud's. I was like, what? Let me find out.
Yeah.
I never imagined when I went into pulmonary fellowship, I would spend so much time looking at fingers.
Yeah. And I wonder how this certainly isn't going to solve the problem, right? I mean, there's people here and there's people online, but I wonder how we can make this more like the knowledge available to the new fellows coming in so that people don't get these calls in the middle of the night. What, a finger? You're sending that to the MICU?
Well, I think this is a start and we can just remind the fellows, maybe do an in-service, but this is how we start. So any questions? Oh.
I do enjoy taking care of your patient's fingers. So, and it's rewarding. I'm curious, where does the 5 days come from? And what exactly is happening during those 5 days and then presumably after those 5 days? Because the fundamental underlying process is still there, presumably.
Yes, exactly. So, to be honest, I don't know where 5 days came from. That came from the European protocol. That's what they do. And that was what Indy and I reached out to them and got a protocol, an existing protocol, and that's what they do. 3 to 5 days, maximum 5 days. So I don't know if that's been studied. Like we don't make patients stay for 5 days. As soon as they feel better, they can leave. They're not held prisoner, but we don't keep them beyond 5 days. The reason why it's thought to be effective because of its such short half-life is it's thought to have healing effects on the endothelial cells and the antiplatelet effects. So it's supposed to help endothelial cells remodel. But I don't think it's been very well studied. We have a study underway to study that. We're doing hyperspectral imaging before outpatient infusions, before the treatment, and then at the start of this next treatment, we're also collecting blood, plasma, PBMCs before they start treatment, and then at the end of the infusion. And our plan was to work with vascular biologists to try to dissect what is happening in the circulation of those patients. But, all I've done thus far is collected the samples and the imaging. We're analyzing the imaging, but the samples are there if anyone's interested in them. Our plan was to do maybe proteomic, metabolomic analyses, things like that.
Hi, thank you so much. This was really helpful. I had 2 questions. One, I think you kind of partly answered with Dr. Siegel's question about what's happening during the crisis. And I find it interesting that you just cold stop the EPO at 5 days or whenever the treatment is over. I had always thought that it was while we transition you to these other oral meds or something. But I'm wondering if maybe this is an acute vasospasm that you're just trying to loosen during that time period to let the body then take over?
We resumed their medicines. So they're all on the oral. These patients are going to be on a phosphodiesterase 5 inhibitor, a calcium channel blocker, aspirin. They're going to be on all those meds. Typically those are held while they're not the aspirin, but the vasodilators are held while they're getting the IV EPO, and then they're resumed when we stop the IV EPO.
Mm-hmm. And then my other question was, why do they need to be in the MICU? And I understand why we do the MICU for our IV epoprostenol for our pulmonary hypertension patients who, of course, could get flash pulmonary edema or acute RV dysfunction. But if someone does not have pulmonary hypertension and we are only using it for their fingers through a peripheral line, and you are also able to do it outpatient sometimes, what is the concern? Is there a concern? I feel like your face
The
is saying.
concern is that it is written all over the packaging that and that persons on this panel saw, everywhere patient can decompensate acutely. And so, once that was read, we tried, to explain this is a much lower dose and, we're going to screen the powers that be have said that this is where it must be given. And you are welcome to revisit that conversation. No, seriously, I think it's a really important point. I think initially when this was started, there was a lot of fear from many different groups of people who are taking care of these patients. And maybe now that it's been, these many years, we could re-engage the parties to discuss again. And Vi will do that on Monday. She'll get right on that.
Got it. Someone will fight the good fight. Okay, thank you.
Someone will fight a good fight.
Thank you. This was really, really interesting. A lot of times I think in the MICU, we see digital ischemia in patients who are there for other reasons, especially those on vasopressors. And unfortunately, a lot of times we're like, well, I don't know, we'll call the surgeon, which I will no longer be doing. But I guess I'm wondering in those patients, should we be doing something like pursuing a skin biopsy? And is there any role for this low dose EPO in patients who have ischemia from other things like vasopressor associated?
That's an intriguing question. I don't know. Would that be contraindicated with vasopressors to be also giving vasodilators?
Or maybe a lot of times it's patients who are sort of out of that like septic shock window, but then have these residual.
Yeah. I think it would be potentially a useful treatment, rather than just letting them necrose.
Because I think a lot of times that's what happens. But like in these patients, they've had long-standing ischemia and still have a benefit from sort of like reperfusion. So I'm curious.
I think that's a really good question and something that we should consider, maybe instituting a small study to do that. I don't know of any data, but then again, I haven't looked at that specific question, so I'd have to do some literature review to see if that's been addressed. I can tell you another patient that I had developed gangrenous fingers almost immediately. She was received, I think it was pembrolizumab, first dose fine, second dose, like within days, had gangrene in her fingers, and she was an artist. And but she did the IV epoprostenol and we spared her fingers. So she was very, very pleased. Again, going to give $10 million to Yale. But so I think it can be used in many different settings effectively. But it's more just like on a case by case basis, but we could certainly try it. I'd be willing to do that.
Thanks, Monique. It was great talk. This question was very interesting.
Yeah.
Because it's a different mechanism. Like we're talking about thromboxane deficiency or excess. And post sepsis, we usually say it's done, like the vascular damage is done. So it's not a state of deficiency, it's an end of extreme vasoconstriction because of norepinephrine, because of what we have done. So it will be interesting if it comes back. It'll be extremely.
Yeah, you saw the pictures that I showed. I was shocked that we were able to, that the body, I don't think it was necessarily the IV EPO, but the IV EPO made it possible perhaps for the natural healing processes of the body to just like kind of die back, is the way I describe it to patients. Like the healthy tissue is gonna put a stake in the ground. And so all the dead tissue, all the gangrenous tissue is gonna, die because it's dead. There's nothing we can do about that. But the adjacent healthy tissue, I think there's a role, for trying to help that tissue recover.
Maybe there's an area, there's a halo.
There's an area, I think, there's an area that's still at risk. And if you can reperfuse it, perhaps there's better outcomes.
Outside the sepsis, of course.
Exactly.
So most of this talk was about how we can help you. Now, let's see if you can help us. I was just wondering two things. Now, first of all, you have patients on inhaled EPO. Do they get more less of this skin?
I don't have patients on it. I mean, I don't prescribe that for
I was just wondering
Raynaud,
if patients
but
are-
maybe we should. Yeah, that's.
I mean, we like it because of long selective,
Yeah,
because it goes, but it affects periphery. So if patients inhale, I mean, that's inhaled EPO is a lot less toxic than IV. So
Yeah.
I mean, if it's, that's one. Second, and just an interesting, there's a thought came to my mind that, these patients, when you're admitting them, like doing if you wanted to, the trial or something, PFT before and after when you give the IV, because some of them may actually have vascular problems with their breathing, particularly if they have a breathing problem. Doing a DLCO before and after they come to the MICU may actually show, like a vasodilator test.
yeah, yeah.
If they actually get better with their diffusion. Just the thought.
No, it's great. I love, better ways of assessing efficacy than looks better or, less pain. I mean, there's really no outcome to follow. So that would be great if we had a quantitative metric to see. Thank you for that. That's a good idea. So thank you. I hope that was
Okay,
helpful.
actually, we have-
Oh, sorry.
We have
Yeah,
a couple
I-
of minutes and
The chat.
we have a couple of questions from the chat. So Dr. Matei says, since Raynaud's is so common in scleroderma, do you treat these patients prophylactically with oral calcium channel blockers and other vasodilators? And are there data that approach prevents progression to severe Raynaud's?
We offer treatment to every single patient with scleroderma of which 95% have Raynaud. So every single patient I see in clinic, I offer them treatment. Most patients do want to start treatment because their Raynaud is so severe. It's very rare when someone with early, aggressive disease refuses treatment. It's usually the patients who've had scleroderma for a long time and they don't want to continue taking a daily medication. And I'm okay with that. They obviously, if they don't think it's helping, we don't continue it. The discussion I have with them is we don't know if it prevents progression. But like I said in the beginning, there are data that show that Raynaud is happening in the esophagus and in the heart. And so Attila Fair in cardiology is doing cardiac MRI and also PET CT scans and rubidium PET CT, trying to quantify changes in blood flow with vasodilation. So I think, the idea is that if you give patients vasodilators, do you prevent esophageal dysfunction over time? Do you prevent cardiac death over time? Because after lung disease, I mean, you all have done a fabulous job of, treating the ILD and the PAH, and after lung, the next leading cause of death in these patients is cardiovascular, and it's not macrovascular disease, it's microvascular disease. So that's a whole separate discussion that Dr. Fair would obviously be the better person to address. But that's the hypothesis, is that by treating the Raynaud, that you prevent some of these long-term consequences. And it has been shown in studies that treating with vasodilation prevents digital ulcer formation.
That is interesting because we think about the overlap with pH. Do this short burst of epoprostenol would have some longer term effect on pulmonary vascular remodeling, if there's a way to figure that out. So, and then there's a comment from Dr. Hutchinson saying that anecdotally, I have seen epoprostenol work for ischemic ulcers from traditional causes.
There you go.
Okay.
Thank you, Gordon. Thank you for joining. Yeah, thank you. Those are good thoughts.
Thank you, everybody.